Final speaker of the session is Manoj Saxena. Manoj is an intensivist at the St George Hospital in Sydney, and he's an NHMRC fellow at the George Institute in Sydney. I know I was speaking to John Chalmers, who started the George Institute the other day, knows you're the future, so we look forward to hearing from you. Thank you.
Thank you. Thank you, Andrew. Good afternoon, everyone. Gosh, these lights are really bright. Yeah, two fantastic talks. I loved your sentiment at the end there, Gert, about trying to be happy with uncertainty. And I think that's a thread that, or being comfortable with it, that's a thread that falls through my talk as well. I think we have a lot of knowledge in this area, and increasing knowledge. In a couple of weeks we'll have the results of the POLAR study that will help us a little bit more with this area. But one of the things we have to do as academics and clinicians is, when you're at the bedside, you have to assimilate all that knowledge into something and actually choose to do something, and you're just doing what you think in your professional judgment is best. And we may not have the evidence to be absolutely certain about it, but we still have to make a choice. And I'll run through that as we go through my slides on this topic. Okay, now I'm struggling with this like Jeffrey. So it is that arrow. Oh, it's the big one. Okay, all right, there you go. Yeah, no, got it. Just disclosures. So I have provided educational and board advisory services to BARD. They manufacture physical cooling equipment, but they have no role at all in the design and conduct of studies that we're involved with. Okay, yeah, so this is on that theme. I put this slide in because I think with TBI research and temperature control, but TBI research in general, the challenges are getting bigger. But there is, through that challenge, the opportunity of growth, because we are growing all the time. 15, 20 years ago, the trials that we did in this area were relatively small. They're getting bigger. We're getting more precise estimates of effects. We've still got a way to go. And yeah, I think as we connect more, we've got the opportunity for growth and to get better answers. This is where we started, or at least the modern concept of using induced cooling for the benefit of patients. This guy in the 1960s, almost 60 years ago, published the first case series. It was actually using cooling for disseminated malignancy in patients who had escaped treatment, who had refractory pain or seizures. That was what he initially started using it for, before he moved on to using it for swelling in the context of traumatic brain injury. There had been reports, for the Greeks, if you go back through the history books, of using ice during trauma, but this was the first kind of published report, about 120 patients. This is actually one of the first devices that he used. So there's a CO2 capsule there implanted in the brain of a patient who had refractory seizures and headache related to a neuroblastoma. And here's a picture of the man having a cigarette and connected to a cooling device that's external, circulating cold water. And there was transient improvement, because swelling obviously reduces with cooling. But the symptoms often returned, and he was articulate enough and observant enough to note that in his first recordings. This is actually a doctor with disseminated malignancy receiving ice therapy. And this is the first cooling blanket that Temple Fay managed to manufacture. The reason for putting these slides up are because I think, in contrast, so we've been doing this for 50, 60 years. We've come a long way, and our industry partners have been responsible for helping with that. I think after the publication of the Hacker study and Stephen Bernard's study in the early 2000s, industry was impelled to innovate as we proceeded to induce hypothermia for people after cardiac arrest. And now we have quite good devices that allow precision and delivery of the intervention. And we have also advanced neuromonitoring. So there's a possibility, I guess, in the future of studying the effect on the neurobiology with induced cooling, which may be something that allows us to work out what the correct dose and duration of the therapy should be. So one point I just wanted to make, this is a nice paper published by Ben Beck, the Melbourne group. I was fortunate enough to be involved in it, but it's the interrogation of a registry in Victoria. They have a very well-organised traumatic brain injury registry where data is collected, and he looked at outcomes, temporal changes, and I think this is one of the challenges in this area. So this is the sum of 2,000 patients over a 10-year period. And you can see from the graph, I'll just go back just a minute. You can see from this kind of stacked plot, as Jeff had put up, that the bad outcomes are fairly significant. Up to about 50% die. And of the survivors, if you want to look at bad outcomes, 70% have a bad outcome in this series. 30% have a good outcome. But like I said in my comment to Jeff, even within that good outcome, there's a lot of disability and there's a lot of adaptation that occurs. And the woman that we had at our meeting in Sydney, she was a bright woman before her traumatic head injury. She was due to go to university, but after the injury, even though she recovered and she could live on her own, she couldn't get to university. She tried. Even her mother went to university and enrolled in a course to help her get through university. But she couldn't even do the course part-time and had to drop out of it. But a change in function, that would have allowed her to persist with a university education, maybe even part-time or a different course, would have made a very big difference to her. She'll still do well. She'll be a teacher's aide. That's what she's going to do. And she'll teach swimming along with her mother in a swim school. But she's very different to who she was. And I still think there are gains to be made, certainly from listening to them, particularly in cognition and maybe communication. And maybe that's what we should be assessing in our outcomes, because it's very important to our patients. This is the data shown over the 10 years of the study, and I think the point that this slide makes is that over the 10 years, despite improvements in healthcare services, resuscitation services, pre-hospital care, all the data that we have from these wonderful clinical trials that we do, there's been no change in that good versus bad outcome. It's roughly 30% with a good outcome, 70% with a bad outcome. So what of temperature? It's a cardinal vital sign. We monitor it intensively. We use pharmacological and physical agents without knowledge really about their effects. But I think what we need, and this is kind of getting to this, I'm giving you kind of the summary of the talk before we go into the data on the evidence. I think some of the data that we need as scientists and also as clinicians is information on how induced cooling changes brain temperature, which is becoming increasingly possible, and also neurobiology as well as cerebral blood flow, because I think the trials that we've done to date are unable to tell us about cerebral blood flow and neurobiology, how we're altering it. And it may be that we're delivering an intervention, but we're not delivering it in the best way, and I think that's something that we do need to consider. So the hypothesis that underlies the question that I've been asked, does it work? So the hypothesis is clearly that induced cooling does have an effect on death and disability after acute brain injury. We're doing some work in Australia and with our partners in Scandinavia. I just wanted to, if we look at the right-hand side of the slide, just make the point on this slide, just the TTM2 study, which is looking at cardiac arrest patients, is going to randomize about 2,000 patients who've had a brain injury. That is 4 or 5 times larger than any traumatic brain injury study that's ever been done. And even with the results of the POLAR study, which is I think 500 to 600 patients when we do have them, still relatively small. And I think this is an issue. The sample size is a key issue. And just bear in mind that we are able to do 2,000 patient brain injury trials now in cardiac arrest, and maybe there will be a time not so far away when we can organise ourselves to do larger trials in traumatic brain injury. So these are the clinical questions that I have when I'm at the bedside. when we talk about induced cooling, there are three questions, and they involve around whether pyrexia control is beneficial, whether controlling ICP with induced cooling is beneficial, and whether getting in very early and just prophylactic hypothermia works. And this is all about the topic, target temperature, does it reduce disability and death? And we'll look at all three of these questions just to go through the data that we have. So as an academic, I feel, and I'm going to rely on my children here to help me out, I'm not sure what to say. Do you know, I don't know the answer to the question of whether cooling actually works. And this acronym that the best way I can communicate with my 15-year-old son is by text message, even if he's in the next room. And I frequently get this, and some of you will know this. This means I don't know. But that's my honest opinion as an academic about the area. I came across this just when I was looking at other acronyms, and does anyone know what KPC means? It's another one that our kids use. Keeping parents clueless. So if you see that... So look, that's just an aside. I think as an academic, I think it's fair to say I don't know the answer. I live with the uncertainty of not knowing the answer to those questions. But as a clinician, we have to make a decision at the bedside. And I think from what we know that there is a benefit with induced cooling for brain injury. And I say that because it definitely works in neonates. So neonates with perinatal birth asphyxia, definitely improved mortality and in terms of reduced disability. So there's 5 or 6 well-done studies, homogeneous brain injury, but the treatment definitely works. And if you look at neonatal intensive care units across the world, the therapy is used, so it does work in a clinical setting, albeit in neonates. The data in animal models is fairly strong and consistent that it does work. And cohort studies, again, there's a clear association with both burden of fever as well as the height or the intensity of fever and adverse outcomes. So there's 3 good groups of information from different sources that support that induced cooling works for brain injury. The problem is, of course, in adults, whether it be trauma, whether it be stroke, or whether it be cardiac arrest, we don't have a consistent signal. The other half of that is, of course, what is the risk of using the therapy? Do you know? So there may be a benefit, but what is the risk? I think the main risk exists around the duration of anesthesia and a prolonged length of stay. So in order to cool someone, you have to use anesthesia and medications to manage the shivering. You will prolong people's length of stay, and you will get nosocomial complications like infection or maybe DVT, but they're treatable. So if you put this all together, there's the possibility that it works, some data, in small animals, in small kids. And the risk maybe is manageable. So what would I do? Oops, here we go. What would I do? This is what I would do, I think. I would say that there's a low risk of harm with the intervention. There's a possibility of benefit. And although it's currently experimental to my mind, probably use it. And we'll get on to what we do with it. And I think this is a good way of framing it because I'm forcing myself to make a decision. That's what I think I should do. I'm acknowledging the uncertainty, but I'm still leaving the area open to research and perhaps answering the question. And we're hoping, we're doing work and others are doing work to do further trials in this area. So, here we go. As part of a clinical team, I think I put this in because I don't work in isolation at my institution. I work with 9 or 10 other intensivists, and it's actually very hard to get people to agree to do the same thing, particularly when the evidence base isn't strong or isn't seen as strong. But there's some very nice guidelines that summarize this. There's a few different guidelines that you can use. So this is from the French Society. I think the French do very well specific clinical trials in very specific patient populations. They're smaller than the ones that we do, and they test interventions very well. And I think these guidelines reflect you know, again, a very considered approach of thinking about what the evidence is that we have. And their recommendations from their process are that you should control temperature with induced cooling. And their target is somewhere between 35 and 37 degrees Celsius if there's no problem with ICP. But for refractory ICP, maybe just a little bit lower. And in kids, and we'll see why they talk about kids, they just suggest normothermia and not hypothermia. And so I've given you a lot of opinion in this first kind of 10, 15 minutes. I'm going to move on and walk through the evidence now. And yeah, look, it is based around low to very low quality of evidence. Oh, just the Brain Trauma Foundation before we get to the evidence. So they're the body I think that most people turn to look for systematic reviews and guidelines. They do make suggestions on vital signs, but they don't make many suggestions on pyrexia control or the use of hypothermia for refractory ICP. They do deal with prophylactic hypothermia. This will probably need to be revised fairly soon with the results of the POLAR study, which should be available within the next month. So getting back to these clinical questions, if we go to the data and what we have available, what is available to help us answer these questions? Okay, so pyrexia control. There's not much there. There are no clinical trials. And if you ever, one of the best things I did at the beginning of my research career was do a systematic review in this area. It was very quick because there was no data. And I got to repeat it 4 years later as I finished my PhD and again find that there were no studies. And so there are no studies to inform us about the question of pyrexia control. And I'll come back to pyrexia control at the end of the presentation, just to show you why I think this is a really important question, and perhaps this is where we need to shift our attention. Let's go. Control of intracranial pressure. Okay, so this is the main data that's available here is from the Eurotherm study. So Jeff showed some data from this. This was published a few years ago now. Peter Andrews' group, mainly a European study, in which induced hypothermia was used to control intracranial pressure. And you can see here there was nice temperature separation between the two groups. And just look at the control group there. It looks really tight at 37. I've got another slide on this a little bit later, just showing the spread. That's very compressed data because it suggests that the control arm is very tightly controlled, but it's all patients, all measurements condensed into 1 point for each day. And I'll show you a bit more detail around the spread of that in relation to fever a little bit later. But in this study, they got nice separation between the two groups, and actually hypothermia was inferior to an osmotic thiopentone-based treatment. And the point estimate for the effect favoured the osmotic. And you can see the confidence intervals are above 1. But the trial was stopped early, and you could interpret this as suggesting harm with induced hypothermia, but it's really difficult, I think, to make statements with certainty about adverse effects in clinical trials because they're mainly powered to detect event rates around 30-40%, which is where the unfavourable outcome is. Whereas the incidence of adverse events are much lower and therefore not so good in terms of interpretation. And I think maybe if this trial continued, maybe the odds ratio would return more towards a neutral effect. But certainly it's unlikely to show a benefit. In terms of prophylactic hypothermia, there's several trials here. I think I've got 2 pediatric ones first. And these make the case again that perhaps there is harm with the therapy. So this is Jamie Hutchison's paper from over 10 years ago. Again, nice separation between the two groups. And in this, again, it seemed like hypothermia. There was more adverse outcomes in the hypothermia group. The numbers you'll see are fairly small. So this is one other thing suggesting that hypothermia maybe is associated with harm. The second study, another study called the Cool Kids study, in which there was Australian participation, so John Becker was involved with this group. And again, there's nice separation between the two groups. And again, the hint that there's more adverse outcome with the hypothermia group. So again, this is why I think in the French guidelines they've suggested no hypothermia for kids. And that's poor outcome there as well on that slide, as you can see, that they're equal in terms of good and poor outcome. And then finally, there's Guy Clifton's study that was published back in 2011. And again, this trial, nice separation between the two groups, fairly early onset of the therapy after injury. And again, there seemed to be more adverse events, more poor outcome with the hypothermia group compared to the normothermia group. Finally, there's a Japanese study that compared 32 to 33 against 35.5. So the Japanese, very specific kind of comparison between the two groups, and they've presented their temperature curves in a different way to the other groups, showing the spread of plus or minus a degree Celsius for 95% of the values around the average point there. And once again, with this, there seemed to be either no difference or a tendency towards more poor outcomes in the hypothermia group. So in terms of clinical questions, temperature and TBI, these are the three questions I have as a clinician, and I think these are the questions that are important. With regards to pyrexia control, I don't know, but with the other two questions, at the moment, it does appear that there may be a signal of harm with hypothermia, certainly in kids and in adults, both for controlling intracranial pressure and also when used prophylactically. But we do have the POLAR study about to be reported, and it'll be interesting to see whether that is consistent with these previous recent studies, or whether there's a different answer from that study. That's very early hypothermia for traumatic brain injury. So I just wanted to make a brief point about sample size. Most of those studies that I've just shown you are of the order of somewhere between 100 to 400 patients in each group. And if you use 40%, 45% or 50% as your unfavourable outcome in the control group, and you're looking for a change in terms of a change that is plausible. So in the bottom right-hand corner there is quite a large treatment effect, so a 10% absolute risk reduction. Some would say that that's implausibly large in terms of a treatment effect. 20% relative risk reduction, you will get a sample size of the order of 300 or 400 patients. If you use a more plausible sample size, this top left, 4% absolute risk reduction, a 10% relative risk reduction, you're looking at somewhere between 2,000 or 3,000 patients, depending on what power you ascribe, 80 or 90%. I think we've done really well to do the trials that we've done, but I suspect that they may still be underpowered to truly detect an effect, and we're looking for too large treatment effects. So is this the beginning of the end of hypothermia or TTM for traumatic brain injury? I still go back to the point I made earlier. I think the technology that we have available to us has evolved, it's changed, and I suspect that we've got some great data, but we're at the beginning of the journey rather than the end of the journey. And we've got a lot to learn about delivering the therapy and its effect on neurophysiology that might inform a better temperature target, or a better way of choosing a temperature target. Now, just to go back to that study that I showed you, Peter Andrews' study, and I showed you this graph of the control group. And I said that the data is very compressed in that way. Peter's given me these data. So this is a different way of expressing the same data. And I just want you to look at the control group here. So you've still got the mean values there. They're the blue circles in the middle, around 37 degrees Celsius. But you can see in the control group, 95% of the values are somewhere between 36 and just over 38 degrees Celsius, or 38.5 degrees Celsius, over the first week after injury. So that is standard care in international sites across Europe. We've also got similar data from Australia. In the interest of time, I'm not presenting it because I knew I wouldn't have time. But we've got data from a retrospective, a point prevalence study, and we've done a prospective study as well. And we've confirmed what Peter's found in his control group of standard practice in Europe. We do the same thing. So we have a fair incidence of temperature above 37.5 and 38, almost 12 to 15 hours per day. And we tend to use physical cooling at around 38 degrees Celsius without using much induced hypothermia in standard care. So that's descriptive data about what our standard care is. It suggests to me that we do tolerate a bit of fever, and that's one of the problems we have in the field, is that we don't have a definition really of what fever is after brain injury. We understand fever for infection, but not a clear definition for fever after brain injury. So just to sum up, I think there is a clear rationale that the intervention should work, and it's there in animal models, and it's also there in neonates. There is a problem in that the adult brain injury trials, we've not been able to find that effect, despite trying very hard. We've talked about the benefits and the risks, and I won't go over them. I think, this is how I feel about the intervention. I think it potentially works, but I'm not certain. There are guidelines that suggest we should be controlling temperature, but they're discrepant, I think, with what we observe in clinical practice from what Peter's described in the Eurotherm control arm and what we found certainly here in Australia and New Zealand. This is a temperature curve of one patient, and I just put this in just because it makes the point. Although we have 50, 60 years of evidence in this area, we've evolved as humans over 20, 40,000 years, and across species, inflammation is the method of cellular repair. And it's not unreasonable to allow a degree of inflammation because that may provide the best milieu, if you like, for repair. So I think our approach of tolerating a bit of fever that we've observed in the control arm of Eurotherm and also here is not necessarily bad. You could do both. You could control temperature very tightly, as the French suggest you do, or you could do what we're doing. I'm not necessarily saying that what we've observed is bad. I just think both are reasonable at this point in time. As clinicians looking after patients, we just need to make a choice and do something. My preference, I think, is to control temperature and avoid fever a bit more stringently than we've observed. But I think we need to study the effect of induced cooling on neurobiology. I think that's really important. And I think brain injury trials probably need larger sample sizes, like the TTM2 study, to really study the effect of the intervention. But before we get there, I think we need to understand a bit more what the intervention is doing to neurobiology. So thank you for listening. And in answer to the question, can it protect the brain? Well, that's a great album from the 90s, and I think it says the answer, definitely, maybe.
I think we've got time for one or two questions. If anybody's got one from the audience.
We're running over time, I think.
I might just throw it to you, Manoj. I think you've got told me conflicting messages here. You need a bigger study.
Yeah.
But you don't know whether you had biologic effect that was appropriate from the study, and that would require more detail, and I think that would lead to a smaller study. Can you just resolve those two problems for me?
Yeah, so I think the technology's evolved and it's now available to us, potentially. Obviously we need to look at what the POLAR study will tell us, but I think when we put all that data together, so we're doing a small study looking at how induced cooling affects neurobiology, and I'd like to see that it actually does something physiologically beneficial in the short term before making a decision on whether we do another large clinical trial. I think we need that kind of data. And also to sort out the outcome issue, because I think what we measure gives us an idea of an effect, but actually what's important to patients might be different to what we're actually measuring. I think those are important things to resolve.
Is there a question up there? Maybe the last question. Thank you.
Can't see a thing.
Steve Keeley from Adelaide. You showed quite nicely that with the hypothermia trials, separation in temperature, but also there was clear separation in ICP in those trials.
Yeah.
As there was also in the trials of decompressive craniectomy.
Correct. Yeah.
So there are two treatments that we know unequivocally reduce ICP, and yet the evidence suggests anyway that if not poor survival, but clearly a signal of harm, a greater number of poor survivors in both of those arms.
Yeah.
So the notion that ICP should be the target of our intervention seems questionable.
Yes.
And therefore, I'll go back to Andrew's question, how are we going to look for something that is like, it's plausible ICP has some relationship to outcome, but clearly reducing it makes no difference. So therefore, should we not be looking much more clearly for another marker that really is in that sequence that leads to a prognosis?
Yeah, look, I think your point is well made. ICP, and actually, look, in other clinical trials we've done, short-term gains in physiology hasn't necessarily translated to a longer-term benefit. But so I should expand on by neurobiology. I mean, there are ways of measuring cellular glucose, lactate, pyruvate ratios, as well as tissue-brain oxygen. I think what we'll see as these technologies become more available, we'll be able to study the effect on those things, perhaps EEG as well, the way it changes, as well as ICP. And maybe that will give us a guide as to something that's beneficial in the short term and robustly beneficial in the short term that then we can explore in a larger trial. In our study, we're doing glucose, lactate, pyruvate, brain temperature, and the target temperature is 36. We may not see enough of a change compared to standard care with a temperature of 36, but maybe reducing it to 35 might benefit. I think that's how we're going to gain information. I hope I've answered your question.
Well, thank you, Manoj. It's such a tough area, and I think we've all enjoyed it. We're all enlightened, and thank you for the other speakers in the session.